Andrea Perez, I'm going to move you over to panelist.
Okay. Okay, great. Let me turn on my video and then I will get started. Okay, awesome. Good afternoon, everyone, and welcome. My name is Veronica Holloway, and I am the Chief for the Center for Minority Health Services here at IDPH. We have a super packed agenda today, so I'll go right into introducing our moderator for today. But before I do so, I do want to acknowledge the great collaboration and partnership between the community departments and institutions that went into making this event happen, and extend my sincere thanks and gratitude to everyone. And now for our moderator. Mona Noriega is the chair for the Illinois Human Rights Commission. Mona was appointed to the commission by Governor Pritzker in June of 2021. She previously served as the commissioner and was board chair of the City of Chicago's Commission on Human Rights Relations. Among her many accolades, Mona helped open the Midwest Regional Office of Legal Defense, which advances the civil rights of lesbians, gay men, bisexuals, gendered, and people living with HIV and AIDS, and later served as its Midwestern Regional Director. A seasoned community activist, she was the Comptroller Mendoza's 2020 LGBTQ Pride honoree. She is also an active member of IDPH's LGBTQ Roundtable. With that, please use your emojis to help me give a warm welcome to Mona. Thank you, Mona. Take it away.
That was sweet. Thank you. So hello, welcome. Good afternoon, everyone. And thank you for taking this time out of your very busy schedules to participate in this very important conversation. We've seen how the monkeypox virus is disproportionately impacting our minority communities, and especially our LGBTQIA communities of color, in terms of who is exposed to the virus, who is contracting the virus, and who is receiving treatment. As a state, we want to make sure that we keep our communities updated on our outreach efforts to not only communicate effectively about the monkeypox virus, but also share with communities across the state that the Illinois Department of Public Health and our partners are doing to ensure equity in access to the vaccine and treatment. We received in advance questions from our LGBTQIA communities of color. And there are 4 questions about the state's response that rise to the top. And so some of those are, how is the Illinois Department of Public Health and the local health departments working to address the monkeypox amongst communities of color, especially Black and Latinos community? What are the strategies for developing and disseminating appropriate, effective messaging? How are we engaging trusted partners and influencers in their respective communities? And what strategies, what are the strategies for developing and disseminating appropriate and effective messaging? We all understand that local approaches in response to the virus might vary. The Illinois Department of Public Health, together with the Chicago Department of Public Health, Champaign-Urbana Public Health District, and Eastside Health District in East St. Louis are here to address these issues, as well as Northwestern University's Institute for Sexual and Gender Minority Health and Wellbeing. After I introduce the panel, I'll ask each of the organizations to speak to each of these areas. I will then open up for questions as well as thoughts and feedback from the audience on what's working and what could we do better. The goal is that by the end of this meeting, we will have forged a meaningful engagement and open opportunities for further dialogue and collaboration with our LGBTQIA communities of color. Before we begin, just a few notes. This town hall is being recorded and it will be available on the Illinois Department of Public Health website by the close of business today. Because of the size of our audience and there's not a chat feature on this call, However, there is a question and answer availability. So if you have a question that has not been addressed, please type it into the question and answer bar, and it will be visible by our hosts. And if time permits, we will ask a panelist to respond. So let me introduce you to our esteemed panelists. So with the Illinois Department of Public Health, we have Dr. Artie Barnes, who joined as medical director in 2021. Prior to that, she was the medical director for the Departments of Infectious Diseases and Specialties at the Cornell Scott Hill Health Center in New Haven, where she had also served as the infection prevention officer. She's also served as the clinical director for the South Central AIDS Education and Training Centers. She has experience in various public health systems across different states and expertise in infection prevention, HIV, transgender care, sexually transmitted infections, and HPV. Also with the Illinois Department of Public Health is Dr. Craig Conover. He is a physician, a board certified in internal medicine and infectious diseases, and a former state epidemiologist. He is currently on contract with the Illinois Department of Public Health for the MPV outbreak. With the city, the Chicago Department of Public Health, we have Antonio King, Public Health Administrator, LGBTQ Health and Outreach Liaison with the Chicago Department of Public Health. Mr. King has over 25 years of experience in HIV/AIDS health education and prevention, beginning as a volunteer in the late 80s with the Chicago area community-based organizations. And Mr. King has resided in various cities, including Chicago, Illinois, New York City, New York, Memphis, Tennessee, and Nashville, Tennessee, and has served diligently in various capacities of LGBTQ program management, health education and outreach, and LGBTQ at-risk youth advocacy. Also with the Chicago Department of Public Health is Patrick Stonehouse. He, him, his, or any pronoun used with respect, has worked in HIV and harm reduction services for over 20 years, most recently with the Chicago Department of Public Health, where he is currently the Director of Public Health Operations for the Community Health Services Division of the Syndemic Infectious Disease Bureau. Candy Kraus is the Champaign-Urbana Public Health District Director of Teen and Adult Services. Ms. Kraus has worked in HIV prevention for the Champaign-Urbana Public Health District for the past 23 years. The MPV testing and vaccination response has been managed by her team, the Teen and Adult Services. With us from Eastside Health District is Zakia Phillips Stewart. In East St. Louis, she serves as the Division Director of STI HIV Prevention and Outreach. Also under her direction is the Ryan White Case Management, Near Needle Exchange Program, and COVID. Ms. Phillips Stewart began her career in 1997 working at St. Mary's Hospital Level 2 Trauma Center in East St. Louis, Illinois. From there, she transitioned to multi-specialty clinic, working primarily with internal medicine and infectious disease until joining Eastside Health District in 2010. Ms. Phillips Stewart has been recipient of many awards for her community service. Do we have, I'm going to introduce Dr. Mustansky. I don't know if he's on the call yet, but he is a health psychologist, tenured professor of medical social sciences and infectious diseases at Northwestern University, director of the Institute for Sexual and Gender Minority Health and Wellbeing, and co-director of the Third Course Center for AIDS Research. Dr. Mustansky is an international leader in behavioral aspects of infectious disease transmission and prevention, and particularly among men who have sex with men and young people. Clearly, we have an impressive panel today. And let me just say in advance, thank you, all of you, for doing all the work that you do. But let me now turn to Dr. Barnes. Can you help set the stage? Can you give us a quick overview on the status of monkeypox in Illinois?
Definitely. And thank you everyone for taking the time to make this cozy fireside chat today. I also want to introduce a couple of other members from IDPH who will be joining us on panel, our leaders of our HIV and STI prevention program, and that's Danny. Danny, I'm going to butcher your last name, so I'm going to have you introduce yourself when you answer a question. Brick Shavana and Andrea Perez, as well as Jeff Maris. And we have, of course, our fantastic hosting crew with Veronica Holloway, Marisol, and Laurie Sanders. So, what's going on with monkeypox? So there's some good news on the horizon here as we've been worrying about what should be our best strategic step next. And the good news is that some of the countries in the world, as well as some of the states in the US that have first bore the brunt of it, like Illinois, we had our first case in June, are already starting to see a slowing down. And the question is, what worked? We've got almost 28,000 people in Illinois vaccinated. We've also noticed that a lot of high risk individuals have just started changing behavior. A CDC survey recently showed that there's been a lot of GBMSM people in that community have started see the end of this outbreak in Illinois, hopefully in the next couple of months as we're seeing the numbers go down. But it's not time to rest on our laurels yet. This time when we're finally starting to turn the curve is the most critical from an infection prevention standpoint, to make sure that everyone can be accurately diagnosed, easily diagnosed, equitably diagnosed with monkeypox and have access to all the services they need. And so I want to save all the time that we have for the questions, but I just want to let you know that Illinois is looks like we are finally turning the curve with monkeypox, and it's thanks to the efforts of every single person in our much loved GBMSM community here. Thank you for making all the efforts that it took to get us here. So I'm going to open the floor back up for questions.
So I think the first one of the dominating questions that most people have wanted to know is how, and so Dr. Burns, of course, if you could answer this question, how is the Illinois Department of Public Health leading the state's effort to address the monkeypox?
Yeah, so to start with, I think our director has one vision and goal, and that is to make sure that we have equitable access, even for sexual and gender minorities of color, which I think has been one of our big concerns. So our first step was identifying the equity gaps. And once we identified them, to start initiatives and outreach activities that targeted those, including this town hall is one of those several activities where we're hoping that we can get some insight into addressing issues that are disproportionately impacting our minority communities. So we were proactive in launching vaccinations and making sure that local health departments had the flexibility in deciding how they wanted to disseminate and how they wanted to deploy these vaccines, because they understand the communities the best. And through that, we've been able to successfully, as I said, vaccinate over almost 28,000 people so far. And that's been a significant achievement. We've tried to adopt CDC guidelines as soon as we've received them, including being able to switch to what they call the intradermal shot, the one that goes right under the skin, and that allows us to stretch our vaccine doses 5 times greater. So with that, we've also try to engage with our legislators to make sure that we were able to get funding for Illinois. And thankfully, with Governor Pritzker's emergency declaration, that was possible for us to be able to even get something as simple as a courier service to be able to deliver vaccine to even rural parts of Illinois wherever it's needed. As we noticed that the outbreak was spreading outside of the Chicago area, outside of the collar counties, into deeper into different counties in Illinois. So our efforts have largely, as I said, focused on making sure that local health departments get what they need and that we can support them in case there are complex situations where they need more help, whether there's an infection in a daycare setting, whether there's an infection in a long-term care facility or a nursing home. How do we contain that as fast as possible? So again, all our efforts have tried our best to keep equity in mind, and we're hoping that this conversation actually furthers the feedback we get from it, also furthers our work in that. Thank you.
Thank you so much. That's actually very clear strategy. Mr. King or Mr. Stonehouse, could one of you talk about what the efforts have been at the city level?
Sure, I'll go ahead and start because Antonio and I did talk about this earlier and he wanted me to start on this one. So our efforts have been from the very first sightings of MPV numbers coming into our city in cases and starting to look at the data, the demographics, the geography. We knew, even though the numbers that we were seeing at that point were predominantly north side of Chicago, predominantly white, predominantly gay, bisexual, and other men who have sex with men, that there was very little likelihood that that was going to end up being the case over the longer period of time. And so knowing those data, we did have focused efforts to inform individuals, to try and get people connected to testing, care, to vaccine when it became available. But we also made sure that we started having some very focused conversations with the rest of the city. So back in the early June, we started having weekly, we call them Monday morning or Friday morning briefings. It was actually a healthy summer for gay, black, or gay bisexual men who have sex with men in Chicago. And it was about MPV, sure, but it was also, we wanted to talk about COVID. We wanted to talk about positive opportunities that folks had coming up over the summer, because quite honestly, the initial response many of us had when we started hearing about MPV was like, no, not right now. We've just been going through COVID for the last couple of years. We've got 4 decades of HIV. We really need a summer off, please. Can we just live for a summer, please? And then MPV came along and was like, no, you can't. And so we very much wanted to have these ongoing conversations where we were able to share the information that we have as the local health department and share ways that we can cope, ways that we can be okay, as okay as possible, while being informed of the risks of MPV and the opportunities to try and address it. And really, we wanted it to be a bidirectional engagement from the beginning, intentionally not just inviting those who are geographically or population-wise focused on the north side, white, gay, bisexual, and other men who have sex with men, but we brought in our delegate agencies and community partners from the south side, from the west side, non-delegate agencies who are in the house ball scene and other kink scenes. We just wanted to get folks together. And even though the demographics aren't indicating you, we know they're gonna pretty soon, because we know from data before MPV that that's how this works. And so from the very beginning, we've been wanting to engage with folks beyond just what we're seeing in the demographics, so that we can get what's going to be the effective mechanism for communication, what's going to be the effective language, what different platforms we need to try and get on. Once we're doing vaccinations, is it just going to be large scale city college vaccinations, or do we also need to have the small, there isn't a sign up, but you just know, for folks to be able to go in? And do we want to think of more individual level recruitment opportunities, so that we can try to figure out how we can get to those folks who aren't going to go to an MPV thing, because everybody knows now that MPV is about gay, bisexual, and other men who have sex with men, and I don't want anyone to see me as that. So what's the path we do for those as well? I'll stop there. Mr. King, anything you want to add?
Well, I did want to add, of course, Patrick. To that end, we understand that the LGBTQ community, even when you say men who have sex with men, that's very layered. And we wanted to make sure that we were able to outreach not just to those individuals who go to bars, but to those individuals who attend churches, those individuals who go to community, and who just attend and aren't just men who have sex with men, or individuals who come in contact with them at bathhouse, such who don't identify. So we started after those conversations on Fridays, we started implementing with our community stakeholders and community agencies smaller vaccination events. Even at one of the local Black gay bars, Club Escape, over 70 individuals were tested that night. Those are individuals, and it wasn't on one of their Saturday nights. It was during the week when they had card playing, when they had other activities going on for a demographic that we normally would not have been able to engage over the weekend. So those are the kinds of situations that we've been looking at, as well as Patrick mentioned, having town halls with the kink and fetish community, engaging the ballroom communities, those individuals who are Latinx as well, who are detached from being called in the data that is seen with the white gay men, who don't label themselves, but who are also interacting with that community, and who are also feeling as if they don't want to be left out in this go around. Like, it kind of was reminiscent to HIV. We wanted to make sure that we did not make some of the same mistakes that we did 30, 40 years ago and just concentrate education and information on one side of the city.
Thank you. Thank you so much for sharing that. Ms. Kraus, can you talk a little bit about your work in Champaign-Urbana?
Sure. Good afternoon, everyone. When we had our first we had our first MVP case early July. And so shortly after that, we started receiving vaccine, and we prioritized our folks that were in our care services as well as our PrEP clinic. And so we reached out to all those individuals to see if they were eligible for the vaccine. And many of them were, and those were our first clients that we saw in vaccine clinic. We also were actively engaging folks who were attending our STI clinic during that time. Again, focused on that high risk populations that IDPH had identified. We mirrored the messaging that Chicago had done, so that many of our residents travel back and forth to Chicago for social events. It was around Pride at the time, and other large MSM events. And so we mirrored that language. So as our residents were slowly becoming educated as to the outbreak that we were experiencing, they were seeing messages. We ran an ad on Grindr, advertising the vaccine and doing some education through that app. And then we also set up a phone bank and email, much like we did during COVID, to allow residents to call in or to email in to get more information on the virus as well as the vaccine. We were able to assess them real time then and schedule them into our comprehensive clinic for vaccination.
Wow, thank you. Thank you very much. Ms. Stewart, can you talk about what your efforts have been in East St. Louis? Zakia? Okay, well, we can go on to the next question. Another question that I think everybody can discuss is, how are we engaging our trusted partners in the community? Perhaps we could start with Ms. Kraus, and then we could do a reverse path.
Sure. We reached out to the LGBT organizations that we have that we work with on a regular basis to first offer education about MPV as well as vaccination available. So we got messages out through Facebook and other social media. A lot of the initial the first month I think of information that we put out was mostly through word of mouth. We had a lot of conversations with our clients and folks we were working with, and so they were able to disseminate the messages. Wasn't too long after we started vaccination, we were able to offer vaccine to folks that lived in counties around us, as they were our clients, as well as expanded that recently. So we were able to reach out to some of the counties around us as well.
We have, again, two city representatives. Could one of you speak about how you're engaging trusted partners in the community?
Well, I mean, I can, some of the things that we did were looking at non-traditional MSM or gay, bisexual hangouts or gatherings, such as we had a presence through our community-based organizations at Bud Billiken, which is non-traditionally someplace that we would not be looking at MSM, but we know that that information needed to be there. We also engaged in our Latin communities, those individuals and agencies that were working directly with the Latin agency on major events that they were having, where we had to implement not just information, but opportunities for vaccinations, opportunities for them to know that there is a call center number that they can dial into to get information for resources, as well as where they can go, whether anyone else, if they were a partner, or if they were exposed. These are individuals where we engaged the major stakeholders in the community, not just the town halls, but the town halls with the kink and fetish community, the ballroom community. We sponsored major balls that they were having and events where we had Howard Brown, or we would have some of our other agencies to be their task force, one place individually, particularly that houses and hosts, I should say, young adults and young LGBTQ members up to 21 years old, some of them over, but a lot of them who don't go to bars and such. These were engaged, and these are stakeholders in the community that were able to reach that community that we ordinarily would not have reached.
So very few things I would add. We, because a lot of our effort flows through our Syndemic Infectious Diseases Bureau, which is HIV, STI, viral hepatitis, and tuberculosis. We have a bunch of delegate agencies and community partners whom we've been working with for years and years and years, with a focus on equity related to HIV services, but also other health outcomes. And so pulling those together, and because we already knew each other and knew who was going to push us and who was going to say, yeah, that's fine, rubber stamp, not many of those, but we knew that we could pull together an active group who would be pushing us forward. I would say that we also, again, this Friday morning brief that we have, it's an open invitation thing. So it started out, we sent out invitations to a bunch of our delegate agencies. Right now there's 200 people who are on that on a weekly basis, and I don't know most of them. They were just received forward to an interested party or a community stakeholder or someone who just wants to know more, or an elected official, and all of that is wonderful. Outside of doing a Facebook Live every week, which we're thinking about doing, but it was just who wants to come talk to CDPH about MPV? Every Friday, and it's just wide open. And the last thing I think I would add is we also, there are members of the LGBTQ communities who work for CDPH outside of it's not a professional qualification, but there are gay, bisexual, and other men who have sex with men who work here. And they might not operate within SID. They might not operate within MPV, but that's okay. You're still a trusted partner because you work here and because you know folks. And so we didn't limit ourselves to our professional affiliations. We just talk to a person whom we know who works here, and you know anybody who maybe we should talk to about this? Oh yeah, my friend over here who organizes sex parties. I don't go, don't need to know, it's fine. But that ability to, there's our professional realm, but then there's also our personal realm, and that is also a place where we can be trusted partners.
Wow, thank you. Thoughtful. Director Barnes or Dr. Conover, can you talk about how the state engages with trusted partners in various communities?
And I'm not the director. Director Bora is not here today, so I'll take the promotion. That's fine. But
promotion.
yeah, I'll have Dr. Conover also speak to that, and also to address some of the issues that looks like Jeff Maris. We've been trying to engage with our HIV partners and our PrEP clinics, Ryan White grantees across the state, who might be best positioned to do some of this work. So I think I'll have Jeff, if you had wanted to respond in relation to that, please go ahead, and then Dr. Conover.
Thank you, Dr. Barnes. Jeffrey Mars with the Ryan White Part B program for the state. And we have been, since the beginning of the monkeypox response from the department's perspective, have been working very closely with our statewide partners that we can leverage through our lead agent portfolio. So our state is divided into 8 geographical regions in which we have um, um, lead agents and case managers that cover the population of Ryan White Part B eligible clients. Roughly around 7,000 are in that portfolio. We have a total of 14,923 that are in our full Ryan White portfolio. And over the last months, we have continued to do information speaking points during our monthly meetings around monkeypox. We've been keeping them updated on the department's protocol and standards, as well as the CDC, so that information is freely flowing and that they have the most current information that the department has. I can share that we have been doing those communications with our case managers and our partners statewide for well over 3 months now, and pretty much on a weekly basis. And then we have worked very closely with senior management at the department, where we have partnered with ensuring that we review and we can provide best strategies for dissemination of information, especially to our most disproportionately disadvantaged and disproportionately impacted by HIV and also monkeypox. And it is our jurisdictional partners that we rely heavily on to reach those areas, because they have developed those very intimate relationships and knowing how to reach them. And so from the care side of the house for Ryan White, we have been utilizing those partnerships, as well as doing mailings to those individuals who hit the targeted population, since we can kind of segregate and glean those out, and we have sent out mailings to them to ensure that they're informed, that if they have questions, they can reach out to our helpline, and that to get access and assistance. And I'll turn it over to our section chief, Andrea Perez, who will talk from the prevention perspective and that partnerships that we have done.
Hi, yes, thank you, Jeff. So this is Andrea Perez, and as Jeff said, I am the HIV/AIDS section chief here at IDPH. And in the interest of time, I won't kind of go in, delve into and kind of repeat everything that Jeff said, but our prevention team has been pretty much in step with our Ryan White team in terms of sharing information and, also at different times requesting information just about what they may be doing that perhaps we're not aware of, so if there are things that that are happening in the different regions that we can share out as best practices or just for information sharing to do. But again, and to avoid kind of repetition, I will just say again that the prevention team has been engaging in activities with their grantees along the same lines as what Jeff just shared for the Ryan White Part B side of the house.
Thank you. Is Ms. Phillips Stewart on yet?
Yes, ma'am, I'm here.
Okay, oh, excellent. Welcome. So we've heard from the state and from the city and from Champaign-Urbana about how they have been able to engage in trusted partnerships with communities. And perhaps you could talk a little bit about how it's working for you in East St. Louis.
Okay, so for us, we're in a unique situation where we have Ryan White Case Management and our STI clinic and PrEP clinic all under the same roof. So we are able to offer the vaccine to our clients when they come in for STI testing, when they come in to see their Ryan White Case Manager, when they come in for the prep visits, and I apologize if it's an echo, but I'm having some audio issues. But we are able to offer vaccines to a multitude of our clients when they come in for various appointments. So, and we're also working with our local FQHC clinics and our local CBOs that offer HIV testing and prevention services. We are also doing social media campaigns that target the high-risk population. We have a close connection with our Hispanic population. We have a clinic in Fairmount City, which is our WIC clinic, but we also do our COVID testing and vaccines there. So we've also incorporated our monkeypox information to that population as well. So we've kind of spread ourselves where we have a multitude of options for our clients that we see. So,
Thank you. I'm glad that you got on. So can somebody talk about what the data is telling us and how we are applying that by using an equity lens? I could start with the state.
Sure, and I think
Medical director, right?
Yes, yes.
Okay, but I can't say director. Does I have to say medical director?
Yeah. So the one thing that we noticed, and I think a lot of our data is influenced by the data from Chicago, which has about 81 at this point, 81% of all the cases in Illinois. And so Patrick and Antonio, you could feel free to chime in on this, but I think the first thing we notice is that, there's a disparity, especially in our Latinx community, between those who are getting vaccinated and those who are the cases and the proportion of people who are infected versus the proportion of people who are very successfully able to reach via vaccination. And, as we've seen with the HIV epidemic, which took decades to get to this place with for monkeypox within a span of a few months, we're seeing a larger proportion of African American or Black MSMs and Latinx MSMs start experiencing or becoming vulnerable to monkeypox. And so the question is, what do you do next? The first step, of course, is identifying the problem. And we have been trying to make sure that our messaging is more culturally and linguistically sensitive to the community. So in the process of developing messaging around that, and also we've reached out to partners who have been doing a lot of work within the Latinx community. Howard Brown Health is one of them who did a lot of outreach efforts in this for these communities. And so I think, part of, as I said, part of how we identify data from an equity lens is to see who's getting it. There's also, we look at it from the perspective of identified gender. And often people don't realize how much data cleanup is required on the back end for those who don't identify as gender binary yet. A lot of forms or testing forms, things like that, only have binary options. And so we have still, as I said, we try our best to make sure that our local health departments are aware and educated and can clear up any confusion about the gender of our cases. For the most part, it's still mostly in what we identify as natal males or people who have a male sex assigned at birth. But we are seeing women also being infected by monkeypox, and our goal is to make sure that we limit spread as much as possible into the general population, because we do not have enough vaccine to really cover everyone, all people of all risks. And so that's some of the ways that we're using data. We're also using data to see how people with HIV are disproportionately impacted by monkeypox and to what extent they're needing therapeutics more than others. And that's something we're keeping our eye onto, and also how vaccination is impacting the spread of the disease. So I'll definitely open it up to Patrick and Antonio and anyone else from the other health departments.
City next.
You want to go first, Mr. King?
Well, I was just going to say that what we have noticed is we've gone from initially 4 and 3% with Black and Latinx to now 14, a little over 14%. I think maybe 16% for Black, and even 20 to 30%, I believe, for Hispanic, Latinx individuals that are infected. But the initial question, I believe, Mona, was, what does the data tell us? Is that what I think?
Yeah, the question is, what is the data telling us, and how are we applying an equity lens?
Yeah, so forget what I said about the percentages, because I'm sure that I'm wrong, because I never get those right. The data is telling us that although it started one way, we know that if we do not get the information, education, and vaccinations out, we will see total inequities in the spread of this infection, of this virus. So the data tells us, just as it did a few decades ago with HIV, that although it's starting with one population or one section of the city and the community, it will and can spread if we don't do something, that we're not proactive as opposed to being reactive. For me, that is exactly what the data says. And I just wanted to make one, I've heard this a couple of times from a few of us. When we're talking about marginalized communities, or when we're talking about communities where we're talking about health disparities and inequities, the idea is to change the verbiage. We no longer want to target them as we want to prioritize information. We want to prioritize services. We want to prioritize resources. So let's back away from the data tells us that we should not target, because marginalized communities are already feeling as if they're targeted by government agencies and by the healthcare system and by judicial system. So as we move forward, I'm twisting this. The data tells us that we need to be proactive and not reactive.
Oh, I like that point. Thank you.
So the only things I would add really are like really diving into the data as much as possible. So going into the case investigation data that we have, we can see that yes, that there's a bunch of app usage that's associated with individuals on cases. Like, cool. But we need to dive in deeper and see, like, of that app usage, what is being used by Hispanic, Latino, gay, bisexual, and other men who have sex with men versus Black, or African American, gay, bisexual, and other men who have sex with men, and so on and so on. So that there isn't just like, oh, everybody's on Grindr, cool, let's go. We need to dive in and see if that actually plays out by each of the different prioritized populations that we have. And I think one of the things that has been an interesting challenge in terms of using the data and looking at the data is that so much of the questions that our community partners have, and that many of us have ourselves, are questions that are about the data that aren't there. So looking at unknowns, looking at, well, who didn't show up to get vaccinated? And what do we know about the people who were informed but didn't show up? What do we know about the folks who heard about it but said they don't believe it, or that they don't see it as identifying with themselves? None of that stuff gets captured in our overall demographics that we upload onto our website, but that is important information for us to be able to craft our overarching as well as our highly focused responses.
Thank you. Ms. Kraus, did you want to talk about what the data is telling you and how you might be applying it with an equity lens?
Sure. I don't have a ton to add to what my colleagues mentioned already from Chicago, but just to say that we're, in addition to those things, we're using lessons learned from COVID and COVID vaccinations real time in this response, because we're reaching out to those same partners, like our partners who work with refugees and immigrants, and migrants, specifically because we know that those populations were the last to the table in large part for COVID vaccinations, and working with some of our PrEP clients to talk about the barriers that they overcame, especially for our Black and African American PrEP clients who overcame some of the myths.
We just ask everybody.
And working with them about what. I'm sorry. Just to talk about, what kinds of things make sense for them in their lives to, because monkeypox coming out of COVID in the middle of the summer, as Patrick alluded to, was not what any of us wanted to do, nor was it what the folks we're working with wanted to do as well.
Thank you. I just want to make sure that we include Champaign-Urbana and East St. Louis so that we don't have, a city of Chicago or just a state of Illinois kind of perspective. So not to put anybody on the spot, but Ms. Phillips-Stewart, did you want to add anything to the question about what the data is telling us and how we're applying it with an equity lens? Okay. So let me ask another question. I know that all of you have talked about outreach to the various communities that we serve. And can you talk a little bit about the cultural appropriate ways of communicating? So, I like the idea of prioritizing communities, not targeting communities, but what is the culturally appropriate ways that you are using to communicate and convey?
This is Candy. If I could
Yes.
kick off just to start, I'm happy to turn it over to my colleagues. I think one of the important things that we've learned in Champaign through HIV work is that engaging communities in large part means employing persons from that community, paying people to do the work needed to curb, insert infection. And so I think that that's a really important piece of this, is that we often, talk about engaging communities by getting messages to them, but we need to incorporate those communities into our organizations in meaningful ways to ensure that the voices are at the table when we're planning these efforts, as well as when delivering messages.
Thank you. Thank you for jumping in. I have a Chicago. Yes.
Hi, this is Zakia. I'm sorry. Somehow I got muted because I have to call in on my cell phone because my computer is not getting along with me today. So I had to use my cell phone to call in. But I was trying to answer that last question in regards to the inequity of the vaccine and what we're doing.
So the question was, in regard to that, was like, what is the data telling us and how are we applying an equity lens? Okay, so from our end at Eastside, the data is telling us is the people that we're seeing that's coming to us don't live in this area. They have found out about the vaccine, and most of the people that we have seen live an hour to an hour and a half away. And they don't live in our jurisdiction. We have the vaccine. They found out we had the vaccine, and they're coming from all over to get the vaccine. Because we are right across the bridge from Missouri, they're coming from Missouri to get the vaccine. They're coming, like I said, from Alton, Grafton. They're coming from all over Southern Illinois to Eastside to get the vaccine because they can't get it where they live. So the people that live in our neighborhood, that live in our jurisdiction, they don't know about the vaccine, and despite our efforts of putting the information out on our Facebook page, having
community events, it's still some hesitancy about getting the vaccine. So, like I said, the people that we are serving that want the vaccine, they're driving to come get it. So, and which is sad that, you know, the people that are in our jurisdiction are not accessing the vaccine and accessing the services that we have, especially the ones that are truly at risk for acquiring monkeypox. So that's it.
Thank you, thank you, thank you. So I see, Brian, you've raised your hand.
Yeah, I was just going to add to that, you know, Illinois and Chicago has a real strong, robust group of LGBT health and HIV researchers, and we've been in fairly constant communication with our colleagues at other universities around the country in DC, UCLA, San Francisco, Johns Hopkins, Emory, et cetera, in Atlanta, to try to figure out how we can better understand spread of monkeypox. Of course, this data that we have at the state and city level are cases that are being diagnosed and folks who already made it in to get vaccinated. And so we're really looking at working with our state and local partners and other colleagues in other parts of the country to understand what is the spread of the infection and who is going in to get vaccinated, what are the hesitancies that people have about vaccination, what are the barriers that people experience, and we're really looking forward to sharing that data in real time as we begin to collect it with our state and local partners. So I think researchers, you know, have something to contribute to this part of the discussion as well.
Absolutely, absolutely. Thanks for raising your hand. You don't have to. I have a ton of other questions, but does the state or the city, either one of you, want to talk about what the, you know, the cultural communications are that you're employing?
I'll start from the. No, go ahead, Antonio.
Well, no, I was just going to say what we did was it goes back to engaging our community partners and those stakeholders, as well as our delegate agencies and non-delegate agencies, on verbiage, on images, the information that we're putting out on promotional packages. What does it look like? Does this look like something that the population that you engage with would be something would pay attention to this? Because if it's not something that catches their eye, and if the verbiage is not correct, if it's in ballroom and there's not something that's wording that they're used to seeing, they won't stop to read the information. So it's called being culturally competent goes beyond saying the right thing. It is also engaging those individuals who know what to say, who know what the images should look like. You can't put on the south side of Chicago two white men hugging up together saying go get vaccinated for MPV, because that's something they're going to walk past and not look at themselves. They don't identify with that. So we came up with, and it was a collective effort from CDPH to our partners to community, a lot of emails going back and forth. But ultimately, there was a myriad of images that we know once we kick off a campaign, this is going to touch, this will resonate. So it's very important. Not only that, what about those places such as barbershops? What about in places where we know people congregate but may not identify verbally with a label? Will the images speak to them? Will the messaging speak? Will the palm cards speak to them, which is a bunch of just words? Will those words resonate? That's all I wanted. Patrick, go ahead.
Nothing to add. Thank you.
Any additional words from the state on that question?
Danny, would you like to answer?
I'm
Danny,
going.
educational materials for our community.
Okay, you broke up a little bit, but I'm going to assume you're going to talk about the social media contents. So I've been creating and looking at developing infographics, whether it is and trying to pay attention to being more socially, culturally sensitive about the content that we provide. So just as Antonio indicated, you know, like I stopped even using MSM. I'm starting trying to use other same gender loving men. I mean, like not everybody who is MSM or who have sex with other men might not consider themselves as an MSM. And those are types of situations. So we're trying to develop different levels of media content because the state is so big. Geography differs. We're talking about rurality, urban, different populations interacting. So we're trying to provide as much of the content so that one, we can interact with the individuals of the communities that are best represented, trying to hopefully represent the communities that they will lock in information to, and so on and so forth moving forward, trying to figure out the different languages, what things might represent. Some things might not be written content, things that we might need to develop, such as like video and audio. Those are things that we are all in consideration that we're trying to push forward for.
Thank you so much. And I so appreciate what that visual communication is, nonverbal but visual. So I appreciate the thought that goes into that. So we have about 5 minutes left of this very informative discussion. I would like to suggest that we could perhaps stay on just for a few more minutes so that until maybe 4:15 maybe. I think we have this format. Because there are a bunch of other questions that are coming in. And if you have a question that has not yet been addressed through this conversation, then if you could use the question and answer feature and maybe we can get to it. But even if we don't get to it, hopefully somebody will be able to follow up if you have that question. So I'm going to start with, so if you have to jump off, you will be able to get this taped and you could see what further conversations occur. But I think if we could stay on till maybe another 15 minutes, there are some other questions that we have received that we would like to get to. So if you need to jump off, thank you so much for your participation. Thank you so much for all the work that you're doing. And thank you so much for reaching out to and valuing and prioritizing all communities. We are all working towards that, and we so much appreciate that. So if you have to jump off, just let me say right now, thank you for all the work that you do. If you don't have to jump off, then I have a lot of questions here, and it's going to be, we won't be able, we only have 18 minutes left. Okay, so if we stay on till 4:15. So let me just start off with Dr. Mustansky, if you're still there, sir.
Yeah, I'm still here. Mm-hmm.
Okay, so can you answer this question? Can the MPV vaccine interfere with HIV and PrEP injectable and non-injectable treatments?
Sure.
Is that a question that you can answer?
Yeah, I mean, I can certainly point to the interim CDC guidelines on HIV and monkeypox, which indicates that there are clinical studies that show the vaccine is the JNOS vaccine is well tolerated, with a similar immune response and rates of adverse events in people with and without HIV, particularly in people living with HIV who have over CD4 count of over 200. There is maybe some questions about the immune effects in individuals with a CD4 count lower than 200. So if that would apply to you, you'd want to certainly talk to your doctor about how you might benefit from the vaccine. But there's, in general, in terms of I think the big takeaway is the vaccine that we have here in Illinois is well tolerated and has similar effects in people that would be on ART, that might be on PrEP. And so there's really no counterindication against getting vaccinated if you're on PrEP. But I think also going beyond that, we know that there is a disproportionate representation of people living with HIV amongst monkeypox cases. And we don't really know necessarily whether there's a biological cause for that or whether it might be a behavioral profile that might lead to overrepresentation. And certainly there's some more research going on that. But I think it speaks to some of the points that folks made earlier about clinics that are providing PrEP, STI testing and treatment being ones that have great connections with MSM that might be at increased risk for monkeypox, and certainly key players in us being able to reach those communities. But we also know that there's disparities in PrEP access, and so we wouldn't necessarily want to exclusively rely on clinics that distribute PrEP to reach diverse MSM that might be at risk for monkeypox. So in general, based on the CDC guidelines, if you're On PrEP, there's no counterindication from getting the JNOS vaccine.
Thank you. So, so taking off on what the CDC says. So according to POZ magazine, around 40% of people with monkeypox are living with HIV, and the Centers for Disease Control and Prevention recently issued new guidance for the prevention and treatment of monkeypox in people with HIV. So the question is, will the Illinois Department of Public Health be revising its guidance to level with the CDC guidance?
I'll let Dr. Conover address this one. This is IT sponsor.
Sure. Yeah. I mean, there's not too much that's going to change in terms of practice, in terms of the new CDC guidance. I think maybe the main point most clinicians aren't aware of is that TPOXX is potentially an option for post-exposure prophylaxis. That's in the IND. So I think in general, we need to do a better job getting TPOXX to people that would benefit from it. And this is just one more possible use for TPOXX for people that can't otherwise get, say, a vaccine for post-exposure prophylaxis.
Will there be any changes happening in the city of Chicago's guidance?
Not that I'm aware of at this point. I mean, this is something we talk about on a fairly regular basis. So not being a clinician, I'm a social worker. This would be a question for one of our medical directors, but I don't recall having heard anything related to that, relating to our need to change. I know that we have been incorporating everything as we go along.
Mm-hmm. So let me ask another question. So another question that has come in, among unsuppressed HIV and greater immune impairment is likely to become a growing concern as the outbreak increasingly moves into lower income communities with more Black and Latino people, groups that have higher HIV rates but are less likely to be in care and on effective retroviral therapy. I know that this has been mentioned before about how this is going to move. What is the outreach strategy to engage with those living with detectable HIV viral loads?
I say go ahead, Ms.
Naya
Stewart.
has a question. Yeah.
I heard it. Did I hear a question?
So
Yeah,
keep trying in. Yep, you're good.
Okay. I wanted to answer that. Like I said, with Eastside, we have our round white case management in-house. So with us, with round white, that we have a quality management group. With each case manager, we have the clients that are that have a detectable viral load. They have a work group with them. So they already are identified with their case manager. So those that fall under that category, we work with them separately to try to get them to viral suppression. So those clients are already identified, and like I said, we kind of work with them special, more hands-on, especially working with their ID physicians, trying to get them on a routine with their medications, making sure that they get their labs done, getting all kinds of treatments in place for them. But as far as the monkeypox vaccine, we are trying to pull them in, call them to have them come into the clinic to get the vaccine, get education. So that's what we're doing here at Eastside, is we're calling those clients to have them come in to see if they're interested in getting the vaccine, because they are more at risk of developing or contracting monkeypox. So.
Thank you. And I'm glad you're still connected to us.
Yeah.
So I know that you,
Can I?
yes,
This is Jeffrey Mars, because I want to piggyback on
absolutely.
Ms. Stewart's comment, because the protocol that I think Eastside is doing, I think is probably one of the gold standards, and that the work that we're pushing out to all our Ryan White Part B case manager delegate agencies statewide is that same one, because within the Ryan White data system, we have pretty much real-time viral suppression rates on the close to 15,000 clients that we serve, both through case management and through the AIDS Drug Assistance Program. So if they're connected to a Ryan White case manager and they're virally detected, that they're not virally suppressed, we have encouraged all our case managers to do a personal outreach to that individual, to give them guidance around what are options and to talk about their options for them. We are also preparing for, because the bigger question, I think, is for those individuals who are connected to the Ryan White program through the AIDS Drug Assistance Program that are not in case management, which is roughly about 60% of our population. We do have the viral load results currently on each of them, and we are working with our pharmacy benefit manager, which is Ramsell Incorporated, who's under contract with the Ryan White Part B program, that is able to do outreach through their adherence protocol module that we have developed with them as a way to reach those who may not have a case manager attached to them, but they're attached to our program. And those adherence outreaches are actually being conducted by trained, approved pharmacy tech through our dispensing pharmacy.
Thank you. I know that you've discussed that there are some MSM who do not identify as MSM. So the question is how is the Illinois Department of Public Health or the City of Chicago avoiding stigmatizing the vaccine, and especially amongst the non-gay identified MSM populations?
I'll jump in since no one's saying anything. Well, I was going to say one of the ways is offering vaccinations through our city colleges, which that particular entity is not gay identified or MSM identified. That's one way, putting that in the community, the south side, the west side, the north side, so that opportunity is there. Now, that's a big dragnet. Will we actually get the population that we're looking for? Maybe not, but that's one instance, and I'm going to let Patrick expound a little more, because that's what came to mind at first. Was one of the ways that we did it with the city colleges, to try and engage the entire community that may be having sex with men but don't want to come to an establishment such as a bar or a bathhouse. Go ahead, Patrick.
I mean, I think two things. There's also like this Venn diagram of communication that I talk a lot internally here, that there is hyper-focused efforts that are, this is communication that we want to go to gay, bisexual, or other SGL individuals. And then there's this broader general population we want folks to know. And we know that there are same-gender loving men who are within the general population, of course, that are going to receive it not through the focused path, but are going to receive it through the general population effort. And so part of it is trying to get the information out that way, through as many different communication channels as we can, putting it onto newspapers, like through our Facebook Lives that engage in general community, through our community health worker efforts, through our delegate agencies and community partners that are not affiliated with same gender loving individuals or priority health concerns for same gender loving individuals. But I also want to say, I think, I just got to be like frank about it. I don't think we have fully succeeded in removing the stigma from the communications. I think everything from when we put forth the data that focuses on what we are actually seeing in terms of transmission within the city of Chicago, I think similar to a question that was put out forth earlier about like segregationist or genocidal communications that folks are hearing like about like this is why we need to like quarantine all gay men, like because that perspective is still present. Any kind of communication that goes out that identifies same gender loving men is going to add fuel to the fire of individuals who are, for various reasons, anti same gender loving individuals. And so it becomes stigmatizing because we are bringing up this very real activity that's taking place. And there are a bunch of people who are going to we're going to take that as an opportunity to fire down upon gay, bisexual, and other same-gender loving individuals. The phrasing itself, was that stigmatizing? Perhaps we can debate on that. But what it does within that context of ongoing homophobia, transphobia, and bigotry is it allows for those individuals who are going to shout out from the rooftops about the horrors of gay, bisexual, and other same-gender loving men, they now have a platform that they're going to speak to. So I think it is a complicated and ongoing thing. Well, one thing I do think like we've tried to do is also like celebrate the sexual behavior that is associated with MPV. Like MPV is a reality. It is a thing that we're seeing in these transmission routes. And so like we want folks to go out and have sex and have fun, but we want it to be done safely. And we want it to be done like make sure that like if you have any of the symptoms of early onset MPV, like all right, well then don't, or like check somebody out if you see them, like if you see a mysterious rash on a person that you were thinking about walking up to, like maybe don't. But if you don't see anything, like, and you got your vaccine, go ahead, nothing wrong with it.
All right, to end on a high note. So I promised, so thank you all for who have stayed on. We only have 4 minutes left of this, so I think maybe I'll turn it over to Veronica to close us out. But let me just say thank you to all of you who stayed in here, and thank you for those insightful comments and the care that you guys, that all of you show to all the communities that you work with. So thank you so much. And Veronica, will you close us out?
Yes. Well, first, thank you, Mona, for doing such a fantastic job facilitating. Thank you to all our panelists. We hope that we can have this dialogue on a continuous basis. And thank you to our community partners for having us have this dialogue with you. I hope that you've taken something out of this. I know we've learned a lot from the questions that you guys have presented. Want to, see our call to action actually for you guys is to be cautious. You heard, you had Patrick say, be safe, seek out a healthcare provider if you think that, there has been an exposure, and get vaccinated. And above all, let's continue this dialogue. Please reach out to me, reach out to any of these panelists. We will definitely be responding to every one of the questions that were posed here, and we will be in touch soon. And with that, I want to say again, thank you. Thanks for everybody that's helped make this come together in short notice, and have a great rest of your day.
Thank you for having us.
Thank you.
Thank you. Bye.
So, Laurie, are you able to save the chat, the transcript?
I saved it, Veronica. So let
You
me
were able to, okay.
Yeah,
But I
let me
think
just confirm that it was properly saved.
okay, not the recording. We want to get the transcript so we can follow up with those questions that were on the chat.
And you are still recording.
Oops. Well, we can clean that. Thanks, Lori.
Val, if I stop recording now, will I lose the chat?
No. Hold on.
Recorded it. I mean, I saved it.
Yep, I have it, and I saved it as an Excel file versus the text file too. So Then you guys can choose which one you want. And the recording, once the recording, you'll also have a transcript of, you know, everything of the, on the recording site too. So discussion.
Awesome.
Okay, I am stopping recording now.